whether it is someone reflecting on their work, a research proposal that's relevant for health system strengthening and services, whether there's opportunities for collaboration that we want to explore. The space is really an open discussion forum amongst peers and friends. And this is also a cross MRC platform, so that anyone from any of the units at the MRC are invited to present, as well as invite speakers from anywhere. So yeah, a warm welcome to everyone. I think, Kim, I'll just check from your side if there are any more people still coming in, or whether we should get started. And maybe we could just make sure that people coming in, if you don't mind muting yourself, just so that we don't have too much feedback. Good. Thanks. Kim, just to confirm, are you recording? Okay, you are muted now, but I saw you nod. So, it's my great pleasure to introduce Professor Louis Reynolds, who many of you may know, but for those that don't know him, he's a retired paediatrician who worked for a long time in intensive care at the Red Cross Children's Hospital in Cape Town. But since retiring, and I think even during his time working, has always been interested in issues beyond simply health, and also issues of social determinants of health and social justice. And it was actually in his capacity as with his involvement with the People's Health Movement that we've invited him to come and speak today, to bring his knowledge and expertise around child health, but also his insights into what he sees as some of the challenges for the health system. So with that, welcome. Thanks a million, Louis, for being here.
No, thanks very much, Tamara. When Tamara approached me, she felt that a bit of context was needed to all the places where we work, really. And so let me try and do that. So what I want to talk about is child health in the Anthropocene. That's which I'll come on to and explain. And the story starts at a place called Verdwaal in the Sobotla municipality in the Northwest Province in October 2011. This is where I turn. And what happened in October 2011 was that 4 children in that area died of thirst and hunger and heat. They were between 9 and 2 years old. The 2 older children, their older sister was the mother of the 2 younger ones. And she had gone to find food for them. She'd gone on an 18-kilometer walk to a farm nearby, 18 kilometers away. And they were so hungry that they decided to follow her. And when she got home later, her name was Kelebone. When she got home later, they weren't there. 2 days later, the bodies of the older 2 children were found in a field. I think where those policemen are pointing to where they were found. And the 2 younger children, their bodies were found only 2 weeks later. The temperature on the day was 32 degrees. So they died of hunger and thirst, and I'm sure they had heat stroke. And they kind of disappeared. Now, in the same year, the editor of the British Medical Journal, Fiona Godley, wrote an editorial. She'd just come from a meeting where they discussed climate change. And it was like an eye-opening experience for her. She wrote the editorial which said that the greatest threat to human health is neither communicable nor non-communicable disease. It is climate change. And she kind of wrote this editorial with a frog in her throat. She felt it took courage to say this because putting something as distant as climate change on the health of busy doctors who are worrying about sick patients and chatting to parents who had sick children and so on, that putting this on their agenda was a bit far. But anyway, she went on and she said, we have to confront it. So why I'm telling this story about these 4 children is because they bring together in one space the 2 biggest challenges facing humankind today. The first one is injustice and inequality. And the second one is the global ecological crisis. So these 2 things come together in this little story. And I'm using that to structure this talk around. So the talk is Child Health in the Anthropocene. Can the NHI stroke UHC project help children survive, thrive, and transform sustainably? By transform, we mean whether they can transform their situation, whether they can become one day active citizens in control of their lives. So my take-home messages, let me just run them out here quickly. At the end of this, I want us to realize that actually it's not about the NHI, because the NHI is something we kind of don't know what's going on. None of us. I mean, I don't know if anyone in the MRC knows exactly what's cooking behind the closed doors where these things happening. I know the bill is going through Parliament and the bill will probably be passed, but we know there's a lot of space between bills and implementation and policies and implementation and so on. So what this is about actually is about a shared vision of the kind of health system that would best serve children. What we mean by the C in UHC, do we mean care or do we mean coverage, and what's the difference? Do we actually understand primary health care in its original intention as formulated at the Declaration of Alma-Ata in 1978? Can the UHC and the NHI deal with the social plus determinants of health? By social plus, I mean the social, political, economic, and commercial determinants of health, and allow children to reach their full potential and their agency. So I think this is really what this is about. And finally, it's about how we, citizens of this country, fulfill our roles as active citizens. We live in a constitutional democracy, and I think that we're only just beginning to understand what that actually means. Now, during this week, 12,000 children will be born in South Africa. If things stay the same, on average, they can expect to live for 60 plus years, 64, 65, somewhere around there. That's what the life expectancy is of South Africa's children today, who are born now. So some of them, on average, should be around in the 2080s. So what kind of a world will they'll have their children? What kind of a world will they be living in? So I want us just to imagine their lives briefly. So they'll be born into a world of massive inequality and social injustice. And this world is in the early stage of a major ecological crisis. It's in a stage where you've kind of said goodbye to the previous geographic era, the era of great stability and constant atmosphere and so on, into a new, unstable, rapidly changing situation. This graph shows you one of these bits of injustice, and it's really income, per capita income in South African households, from the poorest on the left to the richest on the right. Now, of these 12,000 children, more than 900 will be born into households that live below the minimum wage. More than half, about 56%, or 60+% actually, will live below the upper poverty line. This is the kind of world that they'll be born into. And getting back to our 4 children who died of hunger, as things are now, this is November 2019, before COVID came, 10% of children are living in households where there is child hunger. 27% of South Africa's children in 2019 were stunted, meaning they were chronically malnourished. And if children are stunted in their childhood, they become stunted in their adulthood. And this is an intergenerational thing, because their children are very likely to be stunted as well. So that's a situation that the children who have been born during this week are being born into. So now I just want to, in kind of preparing for this presentation, I discussed it with some people, and it's clear they didn't quite get what the Anthropocene is. So I'll just explain it quickly. Sorry, let's jump to a slide there. This is probably the best one-paragraph description I've seen of it. It's essentially, the Anthropocene is the age of humans. It's the time in the Earth's history when the main influences on what happens are us. We are the ones who determine what happens. So the pressures we exert on the planet have become so great that scientists are considering whether the Earth has entered a new geological epoch, the Anthropocene, or the age of humans. It means that we are the first people to live in an age defined by our choices, in which the dominant risk to our survival is ourselves. This is from Achim Steiner, who's the chair of the UN Development Program and the Sustainable Development Group. So just to go a little bit more about this, how did we get here? This represents the Earth's history as a year, in a year. So the Earth was formed about 4,550 mega years ago. That's a million years ago. So that's so 4.5 giga years ago. So if we take today as today at the top there, then photosynthesis started about 8, 9 months ago, June, July last year. And during that time, what photosynthesis does, it takes carbon dioxide out of the atmosphere and, using solar energy, converts that carbon dioxide, takes the oxygen out and returns it to the atmosphere. And the carbon gets kind of fixed in energy-rich organic compounds. So that was about 9 months ago. About 6 months ago, September or so last year, the atmosphere became oxygen-rich as a result of photosynthesis. And then during the millennia that followed, those carbon-dense organic molecules were kind of slowly stuck underground in what we now know as fossil fuels, coal, oil, and gas. So carry on further, our earliest human ancestors, the hominins, arrived early this morning. And the Industrial Revolution started milliseconds ago. Probably it's starting as we speak. And what happened with the Industrial Revolution is the discovery of these energy-rich compounds under the ground, which were then seen as a cheap source of energy to develop with, to build economies with, and so on. So what we did essentially, in about 1790, we set fire to the Earth. We actually ignited this fire. And the fire has been increasing and increasing ever since. You'd think the first thing you do when you fire the only place where you can survive, when you set a fire to it, the first thing you've got to do is try and put the fire out. But we didn't do that. We kept on pouring fuel, coal, oil, and gas into it. So it's now got to the stage where it's kind of uncontrollable and it's spread throughout the world. It's spread into our engines of our cars. It burns all the time, everywhere. And what it does is that carbon that was packed over millennia, mega years, billions of years, that carbon is being returned to the atmosphere. Essentially, this is an act of arson, which is suicidal to human beings. There might be animals who survive this, or plants and so on, but essentially we're committing slow suicide. Okay, so that's the what the Anthropocene is actually about. How long have we known this? This article appeared in a small New Zealand newspaper 101 years ago, the Rodney and Otomatia Times, under Science, Notes and News. Coal consumption affecting climate. The furnaces of the world are now burning about 2 billion tons of coal a year. When this is burned, uniting with oxygen, it adds about 7 billion tons of carbon dioxide to the atmosphere yearly. This tends to make the air a more effective blanket for the Earth and to raise its temperature. The effect may be considerable in a few centuries. So we've kind of known this for a long time, but for some reason or other, it kind of hasn't got into our consciousness. And what Fiona Godley said in her editorial earlier was that by 2100, business as usual will raise the temperature of the planet by 5 degrees. As we speak today, it's gone up by 1.1 degrees since before the Industrial Revolution, since before we started this fire. Okay, now how does this affect children? Children are particularly vulnerable to all this. And this slide shows us this from a recent article in the New England Journal of Medicine on fossil fuel pollution and children's health. So across the top there are the bits of fossil fuel of the crisis that affect children. So it's extreme weather events, like what happened in KwaZulu-Natal in April last year, heat stress, like what happened to these 4 children, air quality, water quality and quantity, food supply, food security and food safety, vector distribution and ecology, and then what they sort of mildly name social factors in kind of American scientific speak, I guess, because these social factors are actually economic, political, and structural, and they are to do with power. So what happens is children get exposed to these things, and as a result, they get all sorts of bad outcomes. Pregnancy, allergies, cardiovascular disease, heat-related illness, immune disorders, and so on. There's a long list, and anyone who can, there are lots of articles about this that people can look up if they're interested. So I'm sorry, there's a spelling mistake here. What I want to get on now is the healthcare system, and in this context that I've just sketched. So this is a drawing of Ivan Illich. Ivan Illich used to be a guru of some of us in the 1970s and 80s, when we were kind of engaged in critiquing the apartheid health system. What Ivan Illich wrote in this book called Medical Nemesis was that the medical establishment has become a major threat to health. What he meant by that is that the medical establishment, or what we would now probably call the medical industrial, or the medical industrial complex, had co-opted people's health. It was kind of taking over people's thinking about health in the interests of commerce, in the interests of power, and so on. He called this social iatrogenesis. It was making people sick. It was feeling that people at least felt they were sick. Now with the climate change, his prediction is even more accurate than it was in those days. Because the healthcare systems of the world are major greenhouse gas producers. They are major contributors. They are part of the fire that's burning our planet. 4.4% of global emissions, that's 2 gigatons of carbon dioxide equivalent, are produced by our health sector. Not ours, but the world's. If the health sector were a country, it would be the 5th largest greenhouse gas emitter on the planet. If you think that Africa, the continent of Africa, produces 2.3% of global emissions, then it's an amazing thing to think that actually our health systems contribute more to than the entire African continent. I mean, it's just a crazy situation. This kind of shouldn't happen. It shouldn't exist. For the establishment that we set up to look after, protect, and promote our health is actually the biggest threat. And again, here you can see who causes the emission, and the people who are bearing the burden are the people who produce the least greenhouse gases, mainly the sub-Saharan Africa and other sort of quote third world countries. And what the Director General of the World Health Organization says about this. Yeah, sorry. Tedros Adhanom Ghebreyesus said recently that on health systems' contribution to climate change, it's perhaps ironic as medical professionals, our commitment is first, do no harm. Places of healing should be leading the way, not contributing to the burden of disease. How do the health systems produce greenhouse gas emissions? Here's a nice little graph. This is from the NHS site in the UK, who've done a comprehensive analysis of this, published in the Lancet. And you can see the direct emissions from the facilities, from burning of fossil fuels. Groote Hospital, not long ago, a few years ago, was burning 10 tons of coal every day in its furnaces. One hospital in one health system. So there's the facilities, it's travel, it's moving fuel from the oil wells where it's produced to the tanks of the motor cars and things, waste, including plastic waste and PPEs that are used once and thrown away. Metered inhalers cause a lot of greenhouse gas emissions. Medical devices, I mean, I won't go through the whole lot, but essentially these are the areas where we can change things. And a lot of it is travel. And a lot of it is because our health centers are so hospital centered, that the big hospitals are far from where people live and provide most of the sort of medical care. So what I've just described is a kind of a global iatrogenic disease caused by the way we set up our health systems. So now I want to get to universal health coverage, or the C in universal health coverage. What does it mean? What does it stand for? And how do we understand it? And I think this is a very important discussion, which I'll be very happy to take up in the question time. But essentially, what's been happening is that the issue, the right to health care is something that is agreed upon. It's been agreed on since the Universal Declaration of Human Rights. It's decades old that we have a right to health care. But there's recently been a shift in the kind of discussion from saying universal health care to universal health coverage. Why? Why is that happening? What it does, it takes health care out of its human rights box and puts it in a commercial box as a marketable commodity, because what you're talking about here is insurance, essentially. It's our medical schemes. We're a long way down this road of changing our thinking about the right to healthcare as a marketable commodity rather than a fundamental human right. So this is a very important thing. This is actually what fuels most of the controversy around the NHI. It's how do you keep this as a right rather than a marketable commodity? And if you read the stuff by Gitesh Solanki and his colleagues who've written about the responses to the NHI bill, and if you see who the people who are mostly against the idea of a tax-funded health service are the people who benefit from this idea of it being a marketable commodity. And that's a disaster for universal health coverage if you think of universal health coverage as a equitable thing. You know, it's universal means for everybody. Health means good quality health care, and the C stands for who gets it and how do they get it. And the key thing is equity. And equity means those who need the most health care should get the most health care. And we have a completely reverse situation where that's called the inverse care law, where the people who need the least health care get the most, and the people who need the most have the least access. This is bizarre in a constitutional democracy. And this is written by Joseph Kutsin, who's a health economist at the WHO, and he's really very clear about this. So when you're thinking about healthcare, you've got to think about one population, not different groups with different benefits and different risk, and so one population and one health system. That's the way to get there. So, okay, what's so what? Let's go back to Verdwaal and these children who died of hunger and dehydration is what the autopsy report said. So can universal UHC prevent this happening to more children in South Africa today and in the future? And why did these 4 children die? Why them? And what really killed them? And to sort of, this is where I'm having difficulty in concluding this presentation because there's so much, so many questions that come out of it. So this is the UNICEF conceptual framework of the causation of hunger. And you can see that malnutrition has immediate causes which operate at the individual level, inadequate dietary intake and disease. It has underlying causes which go from the household into the community and the immediate area around that, and also the services that are delivered. Inadequate care, health services, household food insecurity. So these are underlying. And if you go a bit deeper into the causation, then you find you're getting into the area of the political economy. It's the political economy means politics in terms of power, not of political parties and elections and stuff, but power, and economy comes from a Greek word meaning good housekeeping. So political economy means the power over the household resources and how that power is exercised. So that's when we get down to the grass, to the real fundamental causes that kill these children. They were killed by a long chain, starting with social, economic, and political issues. And where do we go from there? Where do we fit in? Where do health professionals fit in? Where do researchers fit in? Where does the MRC fit in? Where do children's advocates fit in? At which of these levels? Some of them, for example, you know, in the apartheid days, in the days when the struggle was waging, we used to say, we're treating these kids for their hunger and we're saving them from their diarrhea, but then they go home to the place where they got sick and they'll just come back again. And that happened, and it still happens today. So what do children need? What should the NHI stroke UHC actually deliver? Well, what children need, firstly and fundamentally, is they need fair access to the social, economic, and commercial determinants of health. This can only happen if you have collaborative interaction by all state sectors to deliver key public goods and services. They are written into our Constitution and in the Bill of Rights. The state has a duty to progressively implement the rights in the Bill of Rights. Then it's economic justice and social solidarity. How do you develop social solidarity? You develop a social solidarity by everyone feeling that they're part of something. And you can do that through a wealth tax, which will be resisted, and a universal basic income. I think would be the shortest cut. Of course, this will meet with huge opposition. And by universal basic income, I'm not talking about a grant. I'm talking about a right. We also need to regulate the production and marketing of tobacco, alcohol, food, including private healthcare, in my view. That needs to be regulated. That's a duty of the state. And healthcare needs to be delivered by teams. So this is a facility-based multidisciplinary team with a whole lot of people around the family, different disciplines, working in a relatively non-hierarchical way with mutual respect, and includes a volunteer. Secondly, children need an equitable, green, and sustainable health system that cares. So it should have human and children's rights at the center, and we've got tools for that. We've got the UN Convention on the Rights of the Child and the Constitution. UHC should be seen as delivering the right to care and not just providing people with cover through insurance. It should be to do that, it has to be a publicly funded national health system. We have to move the center of gravity of health systems out of the big hospitals and into community settings. We need a radical approach to changing the way we think about health systems. It's actually not new, because Henry Gluckman in 1944 tabled a plan like this in our parliament that was thrown in the rubbish bin. We need openness, transparency, and accountable with full community participation in planning and in development and implementation of health policies. And we need to recognize children as agents of change. Now I want to show you a little video of a child. This is a little girl at Red Cross Hospital in the tracheostomy program. She's 4 years old. She has multiple disabilities. She is dependent on having a tracheostomy for her breathing. And she can change She can do this by herself. And this is better done this way. That's her mother with her. She's looking in a mirror. You can't see the mirror. The mirror's on the left. I'm sorry there's no sound here. That's a new tube. And I think you'll notice here that there's no sterility involved. This doesn't have to be sterile, it just has to be clean. The equipment, that tracheostomy tube is one of 2 that she has, and she changes it every day, like she brushes her teeth. And the equipment is simple and reusable and reused and can last a long time. So that's just an example of someone, a child's agency, and we don't trust them enough. And I think given the right kind of environment, I believe personally that the voting age should go down to 16 and eventually to 12. Anyway, as a final take-home message, there's another thing we can do. How do you take the take-home message home? We have choices. We have personal choices about how we live. And this is my last slide. And I think it speaks for itself, so I'll stop there and maybe I don't have this discussion.
Great. just outside the room, but thank you. Louis, I'm going to move you to the top of the table because apparently then people can see you better as opposed to the side view.
Share up there.
Yeah. Personal choices, but you challenged us to do a lot more. So I think it would be great to take some questions. I'll need Kim's help to see if their hands being raised because I can't see them from here. Questions, comments for Louis, to everyone.
Camera's not breaking.
Kim, and we can't hear you, and you are mute.
Which is the machine one years now.
No, the next one along.
Tamara, can you?
Great. Kim, we can hear you. And I think Gertrude's not muted at the moment. But yeah, what a fantastic talk. Before I want to jump in, I think let's check if there are any questions or comments from others in the room.
I hope there's a bit of an online presence.
There've been about 40 plus people there,
Okay.
but unfortunately I can't see them. Kim, can you see who's there? Or if there's anything being typed into the chat. And we can't hear you. Oh no, we might have to set up a separate.
What's this?
Okay,
Yeah.
there's a hand.
Okay.
Can you hear me now?
Okay. Yes, I can.
There is a
Okay,
question from
lots of...
on the chat or on the online session tomorrow. Sorry, we've been struggling to unmute ourselves. There's quite a few points of discussions on the screen.
So yeah, so comments that have been coming through, I have them on here and up there.
Touchy presentation. It's a touchy presentation.
That's a good question. We are muted, so you can't hear me. Okay. John.
Tamara, there are some hands
yes.
online.
Okay, maybe I can see. Let's see if I can see the hands. Oh,
Okay, there's a question here from John.
Yeah, so there's a question from John there. Should the WHO consider changing the C in UHC from coverage to care? Because it makes much sense from this presentation.
I think, John, I hope you can hear me. I think the shift should be back to care. You know, it used to be care, became coverage. And I think this coincides with the kind of neoliberal thing that happened to us during the 80s and 90s. But you can see this thing about coverage and about divided health systems in many documents. One of the key shifts, another key shift, is the reinterpretation of the Alma-Ata Declaration as the Astana Declaration. So the Astana Declaration is meant to reinvigorate the idea of primary health care. But what Astana Declaration gets wrong is it sees primary health care as a route towards universal health coverage. In other words, you know, the Alma-Ata understanding of primary health care was that it was a broad developmental approach to health. And that included dealing with the determinants of health. It was health as a fundamental human right, health beyond healthcare. It included community participation in everything, which is political. That takes power away from the professionals and puts it in the hands of the community. It included intersectoral collaboration. In other words, the state sectors don't need to work in their little competitive silos, but they work in a collaborative way. And importantly, the Alma Ata Declaration called for a new international economic order, which was more just than the one then existing. But there was a new international economic order that was kind of pushed by Reagan and Thatcher in the late 70s and early 80s, when they started cutting taxes. And the idea is to cut tax so that the public services are undermined, and then they don't work properly, and then you privatize them, you hand them over to yeah. Anyway, so the answer to John's question is yes. I think we need to shift from this idea of coverage to care.
Super. So we have a question from Chris in the chat, and then we've also got a hand up from Laurie and another question from Jacqueline. So just from Chris, how can medical students be good agents for change in the climate crisis?
Chris, where do I start? I mean, I think what happens to medical students, I'm sorry to say this, but it's true. Somewhere between third year and fifth year, they kind of lose their critical capacity because there's so much technical stuff they have to learn. There's a problem with this, you know, you just get too much. You know, I once went around with a dean, one of the deans at medical school, to look at reintroducing primary health care. And we went to all the heads of departments, and every single head of department of the super specialist department wanted more time with students. The neurosurgeons wanted more time to teach neurosurgery. The eye surgeons wanted to teach them more about ophthalmology. Each little specialty, they wanted students to become mini specialists. It's just not possible. And then you lose contact with what's actually going on in the world. So I think this is a challenge that I think we can sort of discuss at forums that we pull together, you know, with students. Because I really think it's important not to go down rabbit holes and to kind of keep some contact with the bigger issues.
Thanks, Louis.
Yeah,
maybe we can hear from Laurie. Laurie, you're welcome to unmute yourself and ask your question.
Hi, Louis. A fantastic presentation, very, very inspiring and provocative as always. I just had a couple, I guess, of reflections and questions of my own. One of the things that we've been so struck by in relation to the COVID-19 response was the ways in which the needs and interests of children were sidelined. So somehow when we're looking at an emergency crisis situation, we tend to focus on the adults in the room and we leave children out of the conversation and out of the response plans. So the question for me is, you know, in addition to the points that you've raised, how do we child-proof our response to the climate crisis? How do we put children at the front and center of our plans around both adaptation and mitigation? And I'm thinking, you know, not just about the heat side of things, but also extreme weather events, like the flooding we're seeing elsewhere in the country at the moment. And I know UKZN has done some incredible work in strengthening early warning systems and building the capacity of communities to know when a flood is coming and to have a response plan so that they can get safely up to higher ground with their belongings. How can we adapt that kind of model to address other problems, such as, for example, fires here more locally in Cape Town? And how do we make sure that children are centered within those conversations? How can we use, for example, schools as a platform?
That's using schools, that's getting back to the intersectoral collaboration. I mean, education is a very important determinant of health. And Yeah, I mean, Laurie, I think that's very important. I think it's a big discussion that. I want to get to Jacqueline Nkoma's question. Jacqueline, where are you? It says external over there, but let me, your question was,
Oh, there, you can, yeah, she can ask her question.
can we hear your voice? Ah, there we go.
Yes, thank you for your presentation. I've really loved it. I joined in late, but nevertheless, whatever I got, I found it very thought-provoking. My question is around taking
Can you
care.
speak
Sorry,
up a
we
little
can't
bit?
hear you.
Sorry, Jacqueline,
Hello.
a little bit louder.
Okay,
Okay,
can you
great.
hear me? Okay.
Yes.
Better.
Okay, thank you. I was saying, I was just making reflections on the presentations, which I found very thought-provoking, regardless of the fact that I joined in late. My question is around taking care to the communities. I was just wondering as to how this can be done. Is it going to be sort of institutionalized care, or at that level there is some other arrangement that one would think about? And also for conditions that probably are complicated, as in the video that you just shared, how would you want, how can we ensure that there's a optimal quality care at that level? And also, how would health workers navigate around that? So that's my question.
Decentralizing.
So I think this is a very important issue. How do we get, we have to move the center of gravity of the system into excellent community health centers that are close to where people live and accessible and that people love, that they want to go to. So to do that is a huge challenge because the establishment likes big hospitals. And the kind of way that health developed through the period of colonization was this kind of based on the essentially the British system where they had hospitals and the colonial system, and it was implemented mainly to make sure you had a healthy workforce to mine the mines and so on. But now we're dealing with a situation where these kind of power relationships have been established. And I think we just need to get involved in policy discussions. And we need to inform ourselves about the good reasoning why healthcare should move into community settings. And above all, we should be mobilizing communities to demand healthcare close to where they live, of good quality. We're going to need to hierarchy. We need less hierarchy. We need less gap between the doctors on top and community health workers at the bottom. We need to develop team approaches. And ideally, the people who work at these community health centers should have a bit of humility. And in fact, all our professionals should have a bit of humility because they have a small role to play. The much bigger role to play are in the households and in the community. And yeah, we need community health workers. We need health committees in various communities. We need them to be accountable to their community, not to the people who pay them. Somehow we need to work out things like that. We really need to think out of the box. But I think your question is extremely important, and I didn't quite hear where you are. So wherever you are, I think these things apply all over the show, really.
I'm working with the Malawi UNICEF country office.
Okay, so UNICEF's got lots of ideas about this, or they used to have in the days of Alma-Ata.
I'm sure they do, yeah. So that's great. Thanks so much for joining and for that question. We've got a couple more questions. One is quite a practical one, and your view on, the the need for travel or not for this research community. You know, should we be doing it? You know, post COVID-19, people are going back to all their travels. What are the implications? And I'll just pull up some of the other points coming through. Okay, we'll have a look at them after this, but maybe just a quick reflection on the travel question from Nandi.
Okay. Nandi. Yeah. So if you have community-centered healthcare, people won't have to travel to the hospital, provided that community center is providing excellent care, not high-level care, not specialist and subspecialist care, but day-to-day, good quality, dealing with common problems, and in fact, doing health promotion. And so that the burden of diseases is reduced and the load on the health system is less. And if it's possible if it's within walking distance or cycling distance, and people are fit enough and, you know, have the capacity to walk or cycle, then, you know, that should be encouraged, including staff. The other travel things are equipment. So a lot of equipment is kind of used once and thrown away because of this need for sterility and packaging and all that stuff. Now that tracheostomy change that you saw, that child will go home with a pipe cleaner, that ribbon that you saw, you know, spare ribbons, and it comes in a little cloth bag made by mothers. So the pipe cleaner, 2 tracheostomy tubes, one that she's wearing and one that's clean. And they clean that tracheostomy tube with soap, water, hang it up to dry, and a pipe cleaner to clean out the inside. Make sure that it's clean and dry. And then the next morning, they change. It's like brushing your teeth. So it's like a routine that you have to remove the biofilm, the stuff that clogs up tubes like that. You don't need sterility, and you don't need to throw everything away after using it once. So there are lots of small things that can happen that reduce the need for travel. But I think a big thing is to decentralize and bring healthcare closer to where people live.
Thanks, Louis. And I see a number of people, really the question, the story of the children whose lives were lost, like you said, they were lost. It was really resonating with a number of people. Thanks, Wanga. And Susan, for your comment about the curriculum and this over-curriculated, with everyone wanting their bits added. There's a number of comments about the story that's come through, and also the recent floods, and just how this is being, you know, that was a story from quite a while ago, but how this seems to be, I mean, it's not gone away, it's rippling through. Yeah, and
So there's an answer from Tony about community area-based teams.
Tony, do you want to speak to that? It would be great to hear from you.
Well, thank you. I'm Tony Westwood in Cape Town. I'm no expert on this, but I wanted to quote this because there are people who are thinking differently, and the Western Cape has been taking a whole of society approach. It's a challenge because people work in their individual ways. The geographical borders of different departments are different, etc. But it's good to see words like this, that those of us who want to see this kind of change, so that we are working and able to do what's good for people's health in the face of changing climate, that these kind of things can be held up as a mirror for us to be part of making these changes at the level of accessibility for the vast majority of people who don't need specialized care. Thank you.
Thanks, Tony.
Thanks, Tony. I don't know how much more time we have. I want to, before we close, I want to just emphasize 2 things. So we have to deal with injustice. That is absolutely critical. We have to ensure that every person, no one is left behind, that every person has access to the key determinants of health. And we have to have a decent health system. And those are not easy because there are tremendous vested interests. There are many examples in history of great plans, great projects being stymied by vested interests. So in dealing with injustice and establishing a decent health system, in the context of the Anthropocene, every year that the planet gets hotter will make it more difficult to govern, because what happens with climate change is you get huge migrations of people from places where they can no longer live. There are going to be parts of this planet that are uninhabitable in the near future. So you have huge migrations, you have pressure on the country that migrations are coming to, you get xenophobia, you get violence. In hot weather, you get more interpersonal, gender-based and violence against children, even in households. So the point is that we have to get ahead. We have to get ahead on both fronts. We have to deal with the climate change issues. I mean, I know there's a lot more to talk about here, but we also have to get ahead with justice, social justice. If we don't get ahead of them, it's going to become impossible to catch up. So we have some good stuff. We have some good things here. We have children and globally, we have children with agency. Children are beginning to take the law into their own hands, so to speak, around the world about climate change. And here too. And we have a constitution that we're not using. We're not using it properly. We haven't got the hang of it yet. So those things are precious. We have to hang on to them and we have to make sure we use them. I mean, I think I've said what I was.
Yeah, that's great. And I think you've challenged us all in our individual capacity. And I think Nandi was speaking to that as well, even as researchers, when we decide to take an international trip, you know, we have to really question, is that really necessary? And then also challenging us in our work capacity to look at what is it that we should be changing there to address both justice
and adapt to climate change.
And adapt to climate change. And we're seeing some comments. I think Tony's point was well made, and it's interesting to hear you were talking about politics and power, the power economy, and there they have health is everybody's business as a kind of byline. But you know, the action behind it we have to see, but that's coming kind of top down and sending a message around things like that. And thanks, Pam. I think your idea there of kind of how do we increase surveillance for deaths that are related to climate change? How are we monitoring that? How are we even speaking about that? Early warning systems, violence, nutrition, they're all coming through. So I guess in wrapping up, Louis, just to say it's been a great start to our forum, and it's been a thought-provoking and excellent session, and we're so grateful for your time and also for everyone's participation. Maybe we can just manage the thing, but yeah.
Is there a question?
I don't know if there's another question there.
Tishungane, is there a question?
I think it was a conversation. He was also wrapping up. So thanks for everyone. Those that are in person, we can invite you for some tea and snacks in the next door room. So for those that aren't, I hope you've got something, some more lined up for yourself later. But again, thanks to Louis, and we hope to see many of you in future meetings and discussions. And we welcome ideas. Louis given me a few. I think Joe Cootson's a great speaker, and I think we could try and invite him to come in one of our future sessions. So thanks so much for, as Kathy says, the excellent provocative presentation. It really, really is pushing us to do more. Thank you. Thanks, everyone.
Thank you. Thank you, everybody.
Bye for now.
So the thing I'm saying is, you said
Can
it's
you
a
take
matter
a
of
picture
choice
with the girls
between
down
the
there?
car
My
and the
teeth.
bicycle. So a few years ago,